I've spent over a decade teaching pharmacology, and I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review course at meded101.com/nurse. In addition, you'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides which you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed to teach you things that matter on the test and in practice. Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the MedEd 101 Nursing Pharmacology Review course. All right, so in this section, I'm going to get into diabetes medications, talk about pharmacology, and of course, some of the most important things that you're going to need to know in practice, as well as on any potential pharmacology and board exams. First off, I just threw this table in there. Great little resource from Pearls. First line pharmacotherapy, we're using metformin, we're using GLP-1s, and we're using SGLT2s. So that selection can vary based upon compelling indications and other conditions that the patient has. But that's really those three medications and medication classes. That's typically where we're going to start. And so those are the ones that I'll go through here as well. If you want to dig in more, certainly take the time, hit the pause button. You can see some of the specifics on which medications are most beneficial where. Again, I'll cover some of that as we get through the medications here. All right, starting with metformin. Historically, this has been the first-line agent by itself. We'd always start with metformin. That's changed in the guidelines. Now we might consider an SGLT2 or a GLP-1 agonist. Mechanistically, metformin primarily decreases glucose production in the liver. That's its primary mechanism of action. One big important thing to monitor here, other than obviously blood sugar and A1C, is renal function. So as that renal function drops, metformin may become contraindicated. So important to monitor kidney function. The number one adverse effect of metformin is diarrhea. It's the one that patients will report the most. It is typically recommended to give this medication with food that can help kind of ease some of those GI side effects. Weight neutral, potentially mild weight loss. So that's a nice thing. Most of our type 2 diabetes patients do struggle with being overweight. There's a low risk of hypoglycemia, so it doesn't stimulate the release of insulin from the body at all. Again, it primarily affects that liver or decreases that hepatic glucose production. B12 deficiency, so this is kind of a unique one. Metformin is associated with causing B12 deficiency. Another thing we want to hold during contrast dye administration, okay, and that's recommended to hold that for 48 hours, can increase the risk for lactic acidosis. So that's always a good one to remember as well. And that is the primary reason why we avoid this medication too, as renal function declines. Metformin can increase the risk for lactic acidosis. Definitely a good test question there. All right, moving on, SGLT2 inhibitors. Brand names, Jardiance, Invokana, Farxiga, those are the most common. Empagliflozin, canagliflozin, dapagliflozin. So you'll note that ending, gliflozin, that is an SGLT2 inhibitor. Okay, so what is SGLT2? What's its mechanism of action? So by inhibiting sodium glucose cotransporter 2, so that's where we get the SGLT2, this ultimately results in an increase in glucose through the urine. Okay, so SGLT2 inhibitors increase glucose excretion through the urine. So urine will have more glucose, and this glucose in the urine can obviously be a food source for various bugs, so bacteria, fungal infections, things like that. So in patients with significant history of urinary tract infections or genitourinary infections in general, this medication could worsen that, could increase that. So pay attention to that. If you see a patient that's being treated repeatedly, for UTIs, for example, you want to pay attention, make sure that they're not on an SGLT2 inhibitor. For diabetes care, pay attention to the renal function for this medication class as well. Typically, as that drops, we can have less beneficial effects there. Now, this class is frequently used in heart failure. Okay, so that's a good one to remember there. It has some almost mild diuretic type effects, where with that glucose goes water. And so it definitely makes sense that this may have some potential benefits in heart failure there as well. Evidence for cardioprotective effects, as well as potential delaying renal progression or worsening of renal function. We also have evidence for that too. So a few important things there with the use of SGLT2 inhibitors. Some of those things I alluded to already with the heart failure indication. It's got that mild diuretic type effect. Can sometimes monkey with potassium levels, so hyperkalemia risk may go up a little bit, and that's particularly true when we've got other meds, ACEs, ARBs, spironolactone. Has been some evidence on bone fracture risk, as well as euglycemic ketoacidosis. So euglycemic meaning, kind of normal, basically within normal range or close to normal range. So, let's say they have a blood glucose of 150 to 200. That's not really that high. In diabetic ketoacidosis, we typically have, blood sugars 400, 500, 600 plus that causes diabetic ketoacidosis. If we get ketoacidosis and that blood sugar is somewhat normal, SGLT2s may be at play here. So important to recognize that. There's been some rare associations with necrotizing fasciitis as well as amputation. There's some conflicting evidence on this, so hopefully we'll learn more on that, but just wanted you to potentially be aware of that. An A1C lowering effect is typically in the neighborhood of a point or less. All right, moving on, GLP-1 agonists. Plenty of medications here. The majority are injections. So we've got some that are once daily. We got some that are twice daily. The most commonly used agents are once weekly injections. Semaglutide or Ozempic is probably the most common one. Occasionally see some Trulicity, that would be dulaglutide. But you can, again, pick this up by the ending, glutide. In general, exenatide doesn't have quite the exact same ending, but it's not used very often either. So again, kind of remember that ending, glutide. That can help you pick it out of a lineup, recognizing that this is the GLP-1 agonist. Now, how do these work? What do they do? So glucagon-like peptide 1. So agonists enhance glucose-dependent insulin secretion. And one of the big things it's going to do is actually slow gastric emptying. It acts like the hormone incretin. Incretin promotes fullness and patients feeling full. And so that is why this medication causes significant amounts of weight loss for patients. Okay, so that can be a really, really beneficial thing in our patients who have type 2 diabetes and they're overweight. In addition, they obviously help lower blood sugars as well. Specifically, they tend to reduce that postprandial blood glucose because, again, we're basically telling the mind that we're full And if we don't eat as much, we're not going to have as big a spike in blood sugar after those meals. We do have one oral medication at this time, semaglutide. It does have some strict administration procedures, and it needs to be administered 30 minutes before food, beverage, and other medications. So that's a little bit of a quirk there with the oral semaglutide, which I think is why you probably prefer, or you see it most often used as an injectable agent. It does lower A1C. Obviously, it's used to treat diabetes. It's usually in the neighborhood of 1 to 1.5. The primary adverse effect is nausea and vomiting. So we've got metformin with diarrhea, and we've got GLP-1s can cause profound nausea and vomiting. And I think the easiest way to remember that is if you're feeling too full, you're feeling uncomfortable, you're feeling nauseous. That's also going to lead to weight loss as well. So if you can kind of tie those things together with this class of drug, I think that can definitely help you remember the adverse effect profile. Typically, we're going to have better A1C reduction than most oral diabetes medications. Again, most of these are injectables, so that's a downside, and they are expensive, and the SGLT2s, I will say, are expensive as well when you compare it to something like metformin. Here's an important test nugget. There is a rare concern with thyroid cancer and risk of pancreatitis. The thyroid cancer is a boxed warning, so pay attention to that. If you've got a patient with a history of thyroid cancer, you're probably going to want to avoid GLP-1 agonists. We do have some cardiovascular protection with this class of medications, and they actually work on the same pathway as DPP-4 inhibitors. So that's like Januvia, and I'll cover those coming up. The bottom line here is we don't want to use GLP-1 agonists with DPP-4 inhibitors because they have that overlapping mechanism of basically increasing or acting like that hormone incretin that I talked about that promotes that fullness. We also have GIP, GLP-1 agonist. This is a combo type of medication. Tirzepatide, that's definitely gaining some favor. Zepbound or Mounjaro is the brand name there. This is glucose-dependent insulinotropic polypeptide, so that's the GIP receptor agonist combined with a GLP-1 agonist, which again helps promote glucose-dependent insulin secretion and also reduces excessive glucagon secretion and delays gastric emptying. So this medication definitely can cause some significant weight loss. I would probably encourage you, especially at the nursing level and monitoring things, it's going to have a very, very similar adverse effect profile to the GLP-1s, okay? There really isn't a substantial amount of difference when it comes to adverse effects here. So, primary adverse effect, nausea, vomiting, GI upset, definitely the most common. Rarely, you may see some pancreatitis, some tachycardia, acute renal failure, potentially due to dehydration from nausea, vomiting, and diarrhea. Boxed warning for the thyroid tumors persists with this medication as well as the GLP-1 agonists. This is a weekly injection. And same as GLP-1s, we want to avoid DPP-4 inhibitors with this medication. Tirzepatide, in addition to semaglutide, tend to have the greatest amount of weight loss, and they are typically preferred if a GLP-1 type medication is going to be used. All right, sulfonylureas. So these are older medications, they're inexpensive, and mechanistically, these stimulate insulin release via beta cells in the pancreas. So beta cells in the pancreas, they release the insulin that causes blood sugars to go down. Classic names include glipizide, glimepiride, and glyburide. Okay, whenever we increase insulin, whenever we stimulate the release of insulin, we are going to cause two really important things to happen. So one is weight gain, and the other is the risk for hypoglycemia. Okay, so definitely remember those two adverse effects when we're talking sulfonylureas. In addition, there may be some cross-reactivity. These do have a sulfa component within them. So if you know somebody who's had a severe sulfa allergy, that may be a caution and definitely one that you'll want to mention to the provider to do that risk versus benefit discussion. Elderly, these drugs can be particularly problematic, the weight gain side of things, but hypoglycemia is a significant problem. And glipizide is probably actually the worst out of all these. Chlorpropamide I didn't throw in there either because it's pretty much never used, but glipizide definitely is probably one of the worst ones because it hangs around a little bit longer in the body than some of the others. And, particularly in patients with poor renal function and who are generally older, it can be a significant issue there. All right, DPP-4 inhibitors. So that would be like sitagliptin, saxagliptin, brand name Januvia for sitagliptin. That's the most common one I would say I see. These prolong incretin effects, which incretin is responsible for promoting fullness. So this medication is going to be weight neutral to weight loss. The big difference between DPP-4 inhibitors and the GLP-1 agonists, GLP-1 agonist acts as basically an exogenous source of incretin, and DPP-4 inhibitors kind of preserve the body's own incretin. That's the way I typically differentiate these. So with that being said, if you give more incretin or more incretin from outside the body that's, not kind of under normal physiological circumstances, you're probably going to get a greater effect. And indeed, that's what we see. GLP-1s tend to lower blood sugar and promote more weight loss than a DPP-4 inhibitor. The good thing about these, they are all oral. They're pretty simple, straightforward. We've got some dose adjustments specifically for sitagliptin in CKD. Rare associations with pancreatitis. Generally, these are pretty well tolerated, but we don't get a ton of bang for our buck in blood glucose lowering, compared to something like GLP-1s. TZDs, the only medication in this class is pioglitazone. Brand name is Actos. These, pioglitazone binds peroxisome proliferator activated receptor gamma, and the end result of this is it helps improve insulin resistance in adipose tissue. Okay, so it allows for better insulin uptake, if you will, in the periphery a little bit. There are some downsides to this medication for sure, and that's probably why you don't see it too often. It can cause some weight gain, and probably the biggest thing that I've seen tested is it can cause some edema, and it can exacerbate heart failure. So if you have a patient with heart failure, you are likely not going to want to use one of these medications, or I guess the only one in this class now is pioglitazone. So avoid pioglitazone in heart failure compared to the SGLT2s, which actually have beneficial effects potentially in heart failure. It doesn't stimulate the release of insulin or anything like that, so usually when it's used by itself, we really don't cause much hypoglycemia. One other kind of rare thing that's been associated with pioglitazone is the risk for osteoporosis. Alpha-glucosidase inhibitors, I'm not going to talk about these too much. Acarbose is an example. It's been a long, long time since I've seen them used. They actually prevent the breakdown of complex sugars in the gut. Frequent dosing and significant GI adverse effects. That's really the big deal. I mean, that's why these medications aren't used very often anymore. So that's really all I'm going to say about them. Glinides, These are, kind of similar in a way to sulfonylureas in that they stimulate insulin release. These need to be dosed multiple times per day with meals. Repagliflozin is an example of a medication in this class. Not going to spend much time on it. They aren't used. Frequent dosing, hypoglycemia, lots of problems, and we got a lot better medications to use for diabetes than these. Just quickly on A1C lowering, metformin, GLP-1s, they tend to be, kind of at the top of the list as far as A1C lowering. SGLT2s do a decent job. Sulfonylureas do a decent job as well. Can be in that range of 1 to 2 points of a drop in A1C. DPP-4 inhibitors and TZDs like pioglitazone, they tend to be a little bit weaker, generally less than 1 on average for that drop in A1C. Struggling with nursing pharmacology? Would you like a resource you can put in your hands? You're not alone. If you want to understand medications instead of just memorizing them, check out the MedEd 101 Guide to Nursing Pharmacology on Amazon. Written by a board-certified clinical pharmacist, this book breaks down high-yield drug concepts, clinical pearls, and real-world examples that actually stick. Perfect for exams and the bedside. Whether you're in nursing school or already practicing, this guide helps you build confidence with medications fast. You can find a direct link to the 233-page book right now at meded101.com/nurse. That's meded101.com/nurse.